let's put our hands together and see. Oh, before he comes up, I met my secretary this morning. So I was about to enter. I saw him park his bike. I was like, oh, Sabnang, what are you doing here? So he told me that Dr. Anu invited him. And not only him, he has invited a whole lot. If they are not here, probably they just choose not to be here. So I was so surprised. He has been a very great help. Mr. Samnang, please, can you stand? Okay, please, let's welcome him. So we are all in the same province. You understand? Praise the Lord.
You want me to start now? Okay, good morning, everybody. I know some of you. Welcome, Samlang. I'm very happy to see you. My name is Anu Sinha. Should I go in here? On top here? Yes, my name is Anu Sinha. I'll give you a little short introduction about myself. I was born in India. At an early age, my parents decided to emigrate to the United Kingdom. So my schooling, college, university was all in United Kingdom, and I graduated in medicine in 1998. After junior hospital training, I entered clinical practice and joined my father in his clinic, my mother and father in their clinic, and I was there for a very long time and really enjoyed it. I love medicine, and when my younger brother joined us, he graduated as well as a doctor. I settled him in. Then I decided to travel, and I was traveling Southeast Asia, and I traveled to Thailand, Vietnam, and then I came to Cambodia. And I don't know, it's hard to describe, but I really liked the way of life, the people, and I decided to pit stop in Cambodia, in Phnom Penh. And after some consideration, I decided to start clinical practice in Cambodia. I wish I did. I opened a clinic in Phnom Penh, and then that was doing quite well. Then I opened a second one in Phnom Penh. And I was in here practicing in my clinics for about 5 years. But unfortunately, I had to go back home to London, some personal issues, and I closed them because I had no intention of coming back. So I closed them and I returned back to London. And the reasons I had to go back eventually all settled down. And I spent a year back home in London, and I returned back to Cambodia. And I said that, what am I going to do? So I decided to take a break from medicine and decided to enter teaching, because I had been teaching doctors back home and medical students. I had an interest in teaching. I did the TESOL course, and I landed at AI school at Mao Zedong campus. Hence my connection to Miss Mercy, my colleague and my dear friend. So, a couple of weeks ago, we have an annual teaching conference at AI, and I was asked by one of the teachers, actually, Mr. Stephen Lee, if I would do a talk on, the title of that was Common Medical Conditions That Affect Teachers. Now, a lot of my colleagues know, I don't go around, because I'm not a doctor there, I'm a teacher, but they know that I'm a doctor. And a lot of the teachers come and talk to me about certain things, medical conditions. And I was noticing there's a pattern going on, and whether it was a coincidence or what, there was like 3 conditions that kept coming up quite frequently. Headaches, migraines, uncontrolled sugar, and uncontrolled blood pressure. And that was the basis of my talk. And I will be talking about that this morning. My slides, I think, are coming on the screen. Pastor? I'm going to stay away from medical terminology as much as I can and keep the language very, very simple. Sometimes I speak too fast. If I do, please put your hand up. Students tell me that, and some tell me they don't understand my accent. So are the slides there? Just waiting for the slides. Okay, let me start talking without the slides. Um, One of the most common conditions in the general population, let's leave teachers aside, are headaches and migraines. And there's very clear differences between headache and a migraine, okay? I'm going to keep it very, very simple. I'm sure some of you in this room have suffered a headache, perhaps not a migraine, which is much less common. But I would like to give you the picture we see. So a headache, what is a headache? Headache is a dull ache. It could be in the front of the head, we call frontal headache, or the sides of the head. That's called parietal. And they don't last for too long. It's a dull ache, okay? You don't have any other symptoms really. May get some problems with your eyesight, may feel a bit sick, and they don't last too long. So what's the treatment? What's the cause? Now, before I come to the cause, when I mentioned the three conditions, headaches, let's put headaches and migraines together, sugar, high sugar, and high blood pressure. One thing that is common to all three. One thing. Can anyone like to think what could be common to all three of those conditions? It's a response of our body to a physical or emotional stress. Miss Mercy. This is the second slide. Should we go to the first one, please, Pastor? The first one is just the three conditions. Okay. Yeah. Okay, we can go to the next slide. Okay. Next slide. Okay, right. Here we have it. So, 1, 2, and 3. Headache, migraine. I put them under one title. Uncontrolled sugar, uncontrolled blood pressure. The fourth one I haven't mentioned yet is TATT, TAT. Tired all the time. Now, we go to the next slide, please. I've mentioned about the headache. So, it's a dull ache on either the frontal, top of the head, or can be the left or right side of your head. Migraine, on the other hand, is typically affects one side of your head, and it's a throbbing pain, a throbbing pain. If you speak to people with migraine, they will say to you, it's literally like someone hammering their head with a hammer. Who said yes? Oh dear, sorry. Hope you, yeah. So they'll typically tell you it's like someone banging a hammer on their head. And these migraine attacks can last from hours, unlike headaches, which don't last for more than a short duration. Let's talk about minutes, a couple of hours to days. And in the most severest form, people actually think they're dying. They think they're dying because of the effect of this throbbing attack on their head that's going on for hours and days. They can also, and most commonly, get problems with their eyesight. They can get blurring, see black dots, and there's also nausea, wanting to feel sick, or actual vomiting. Thank you. So these are the symptoms of headache and migraine. And I mentioned to you earlier, there's one common factor that is a big culprit for all three. It is our own body's response to a physical or emotional stimulus. What do I mean by that? For example, it could be to do with our personal relationship. It could be an effect of our professional working life. And we get affected. And our body has a response. It releases chemicals, or you can call them hormones, called adrenaline and cortisol. These increase blood pressure and heart rate. Do you know what I'm talking about, anyone? Thank you. Hello? Hello? Yeah, do you know what I'm talking about, anybody? What is this culprit that comes under the most common cause for headaches, migraines, uncontrolled sugar, and uncontrolled blood pressure? Stress. Now, you often can speak to your friends or family or colleagues, and they may say to you from time to time, oh, I'm too stressed out. I'm stressed out. But is it the feeling of stress, or are they just using that term loosely? There's a physiological response when we are stressed out, when we're under pressure. Our body reacts and it releases hormones, adrenaline and cortisol, which have a direct effect upon our body. They increase heart rate and blood pressure. As a result of that, these conditions occur, okay? Not the only reason, not the only reason, but it's a common factor for all three. Next slide, please. So, okay, we just wait. I can keep talking about this for a few minutes. Uncontrolled sugar. Now, this happens very commonly in people. Now, they could be a known diabetic, or may they not be a diabetic. Diabetes, I'm sure you may have heard of diabetes, is high sugar in your body. So, when someone shows me a blood result of a sugar level, I want to know, firstly, is that fasting or is it random? I don't go too much on random blood sugars because they're highly inaccurate. Because you could have had a heavy meal that had a high sugar content, no history of high sugar previously, and you go for your blood test, sugar may be high. That's what we call false negative. We'd prefer a fasting blood sugar to get a more accurate level of your sugar level in your body. So you fast overnight, nil by mouth from midnight, go for your blood test in the morning. Let's have a look at that one. And it should be less than 7.8. Now, if it's above 7.8, we want to know how high is it? Is it mildly above or is it quite largely above? Mildly above, we stick to dietary advice. Do not start any medicine and review it maybe in a month, depending on the sugar level, okay? So, we must always take a detailed history. Okay, we want to know about family history, lifestyle habits, any other medical conditions, but you will have some symptoms with high blood sugar. The first picture is of a bathroom. Why have I put that there? Because you get a condition called polyuria, where you're urinating very, very frequently and typically at night. That's the first thing. The next picture I put up is water. You feel very thirsty, more than normal. That's called polydipsia. You're drinking water. You have a thirst quench. You need to drink water very, very frequently. And the third one are the bathroom scales. You start losing weight. So these are the three symptoms we will find out from taking a history from the patient. Let's leave that aside. High sugar, okay? With a history of past history of diabetes or not. Number two, blood pressure. Now, this is the silent killer. When I talk about silent killer, this is the silent killer. I want to explain this, and this is a very, very important point I'd like to share with you this morning. 85% of people with high blood pressure do not know they have it. They do not know they have it. We call that asymptomatic. There are no symptoms. You're walking around with high blood pressure. The duration matters. How long? Is it weeks, months, or years? My own grandfather, throughout his life, he never consulted a doctor. He was never sick. Unfortunately, he died of a stroke. The stroke is the common endpoint of walking around with high blood pressure untreated. So normal blood pressure is a range. It's not one level. It's between 130 to 140 over 70 to 85. I haven't got a whiteboard, so I have to say it verbally. 130 to 145, the top level, and the bottom level, 75 to 80, okay? But you don't diagnose blood pressure just on one reading. You must take a series of readings, maybe 3 over the period of 4 weeks. You don't go on just one reading. So, my first point is this. Anyone, and people are getting medical conditions younger these days because of our lifestyle. I would recommend anyone above the age of 35 should get a blood pressure check at least once a year. Because if it's consistently high, it must be treated. You take a history from the patient, and you may have to start medication. Also, depending on the level of the blood pressure. So that's the first point. Second point, go to the next slide, please. So 85% of people with high blood pressure simply do not know they have it. 15% may complain of headaches or visual symptoms. Maybe some blurring, or you see what we call halos, black spots, right? Only 15%, 85% you do not know. Okay, that's what I call the silent killer. Go to the next slide, please. Okay, some of the complications you might get. Now, high sugar, diabetes, is something you really do not want to have. There's no cure to diabetes. It's the object is to control the sugar level. Because the reason of that is, when you control the sugar level, you are unlikely to get complications. And diabetes, the complications start from your eyes all the way down to your feet. Picture of the eyes can happen. The first one is called a cataract. A cataract, basically, in your eye is caused from consistently high levels of sugar. It's an effect of that. And the lens of your eye is blacked out. You can't see. So these people need an operation to remove the cataract. That is because of uncontrolled sugar over a long period of time. Number two, the picture, the previous slide. I said complications occur from your eyes, throughout your body, ending on your feet. The second picture is of your foot. The darkish coloring there is what's called a gangrene. The blood supply has been cut off. That has to be amputated, has to be cut. That is from direct effect of persistent high levels of sugar. This person has been checking their sugar regularly and just thinking that, oh, I've got that machine at home to check my skin test. It was fine on Tuesday. On Wednesday, I'll stop taking my medicine. No, medicine is for life. And it must be controlled. Blood pressure must be controlled, as with sugar. When you control the sugar, you are unlikely to get complications. The third picture I've just put is of the kidneys. You get kidney failure. But I said in diabetes, you get complications from your eyes up until ending at your feet. So the idea is this, the goal is this, is to control the sugar. So we start medication. If the initial fasting sugar is at a level to treat, mildly elevated will be dietary advice with review. If you're diagnosed with diabetes, you need annual blood test monitoring. Some people will go further and do it every 6 months. Fasting sugar. And there's one indicator in your blood test called HbA1c. That is a measure of your sugar control. And we look for that level in every diabetic patient, whether they're type 1 or type 2. Right, that's my picture of the high blood pressure complications. That's a ticking time bomb. I mentioned to you earlier about high blood pressure, the ticking time bomb. So we don't diagnose blood pressure solely on one reading. There must be a series of readings and should be ideally taken at the same time. Maybe 3 to 4 readings over 4 weeks. You do not diagnose blood pressure on one reading because your body has a circadian rhythm and the blood pressure can vary during different times of the day. Next slide, please. Okay, I just want to come to this slide. This is a bit of health screening, which is useful, okay? So, this is very relating to any member of your family who have a family history of the following conditions. Unfortunately, these things run in our genes. So you have a higher risk of developing these conditions. Not all of them, but common things are common in medicine. And I'm mentioning the common ones. So if you have a family history, now, first degree relative. So that's mother, father, sibling, not uncle, auntie, grandmother, grandfather. First degree relative. If they have a history in your family, heart disease. What is heart disease? So heart disease could be blood pressure, runs in the genes. Could be irregular heartbeat. Could be chest pain. You should have routine tests done. And people are getting heart problems at a younger age these days because of lifestyle. So it is recommended by the World Cardiac Association, men above 35, women above a little bit higher, 40, should have annual checks. If you have a family history, you want to do that as a priority. Okay, ECG is a heart trace. Blood tests, sugar and cholesterol. Cholesterol is another silent killer. You have high cholesterol, you don't know. High cholesterol causes blood pressure. High cholesterol causes, high blood pressure causes stroke, okay? It's a chain effect. Cholesterol is something we acquire from our diet. It's not something given to us. It's purely from your diet and lifestyle, okay? Diabetes, strong family history, both type 1, type 2. Let me make it simple. Type 1 are people who take insulin, type 2, oral medication. Family history, okay? So you must do a fasting sugar. If you're one of those people with a family history, first degree relative, mother, father, brother, sister, you should have fasting sugar blood test, cholesterol, HbA1c. HbA1c is a measure of sugar control. That is the gold standard in any diabetic patient and tells the doctor how well your sugar is controlled. Epilepsy, if you get fits, okay, not so common, but there's a family history in that. We want to know. We had a colleague of ours, unfortunately passed away last term. Now, the history came out afterwards that he was a known epileptic. None of us knew that. And one morning, early in the morning, he was having fits at home. Unfortunately, he passed away. Now, any epileptic has epileptic review with the doctor at least once a year again. And the things we want to know, when did you last have a fit? Have you had fits quite frequently? Because the medicine must be titrated. There's no blood test for epilepsy. It's on the history. So there's no cure for epilepsy, like diabetes, like blood pressure. It's all about control. We want to know how many fits you've had, if you had any in the previous 6 months. Have you been fit-free? If you've been having fits frequently, we need to look at the medication. Has to be reviewed. There are no blood tests. It's all about control. Cancer. Now, this is the big C. Which ones have a family history in cancer? Lung cancer, first degree relative, mother, father, brother, sister. Okay? That person, male or female, annual chest x-ray, please. Breast, ladies, family history again, high likelihood of acquiring it. That's the way it is. But prevention is better than cure. Mammogram, annually for ladies. Bowel cancer, this is the one that people just take very, very lightly. If you start getting blood in your stools, do not dismiss it. Whether it's light brown or dark brown, need a stool sample. If you have a family history of bowel cancer, annual stool samples. It's called fecal occult blood testing. Okay. Cervix, females, family history, cervical swab. For all yearly blood tests and blood pressure check. Okay. Just last thing I mentioned there, with women who wish, who are in a relationship, are married, are finding problems in fertility, not having a child, we have to check 2 hormones in the lady. It's called FSH and LH. It's just a check, okay? Next slide, please. This is the last slide. This is just a little brief account of what you actually find from blood results. So, if you go for full blood count, you're going to find out a few things. If the blood count, red blood count level is low, anemia. Treated by increased iron intake in your diet and iron tablets, okay? That's the number 1. Thyroid. Someone is feeling very, very tired. 2 things that come to mind are anemia and thyroid problems. So we do a thyroid test. If it's low, you're hypothyroid, you're feeling very lethargic, you're putting on weight, you've got no energy. As opposed to hyperthyroidism, you're constantly on the go. Blood tests will tell us that. Ferritin, again, low ferritin equals anemia, low iron from your diet. Cholesterol. I mentioned cholesterol is a silent killer. Cholesterol blood checks, I think, should be mandatory in anyone above 30. Okay? Not to be taken for granted at all. And the last one, I didn't say last one, but the that is the synopsis of what I wanted to talk about today. Thank you for listening. Do you have any questions? Of course.
Thank you, doctor. So my question is, if someone is having a constant, like, constipation, what could be the cause and the cure?
Okay, constant constipation. Good question, madam. Number one, increased fluid intake. Diet. Constipation occurs commonly due to decreased fluid intake, number one, and foods that cause constipation. These are generally oily, fatty foods, okay? So, increased fluid intake, treatment, dry fruits help before we start medicine for constipation. So first is increased fluid intake, all right? Increased fluid intake, high fiber diet. What do I mean by high fiber diet? Roughage, brown bread, rice, green vegetables, these all help the bowel mechanism. But increased fluid intake is the number one. If it's persisting for more than 3 to 5 days, and there's minimum bowel movement, start medicine. Common ones, medicine is not very difficult. It's really quite easy to treat. But, so we want to, take the history from the patient. How long has it been happening for? Has it been happening frequently?
Frequently, and sometimes last for a week.
And what was the advice? Was there increased fluid intake after that? High fiber diet?
Yeah, exactly. High fiber and increased fruit, like taking a lot of beverages to help soften the stomach.
Right. Did it help?
No medication.
No, so just on diet?
Yes.
High fiber, increased fluids?
Yes.
That's fine. Because at that stage, if it didn't settle with that, continue the increased fluid intake, high fiber diet, and medicine. Is that okay?
Yeah. Thank you, sir.
You're welcome.
Thank you, doctor.
Yes, sir.
I've been experiencing this heartburn each time I take fried something.
Right. You've just answered your own question.
Yes.
Fried fatty foods is the number one culprit for heartburn. And second one is eating late at night. How long does it last for?
Once I experienced it, I used to take water.
Right.
Take water. It normally happens at night. And sometimes
yes.
I fell asleep, and when I wake up, I can't see it again.
Yes. Typically it can occur at night or after eating a large meal. So water is okay, but better is, in the first case, semi-skim milk. It's an antacid. It decreases acidity in the stomach. Semi-skim milk. Okay, semi-skim. Yeah, we get it here everywhere. Semi-skim milk is much more effective than water, sir, because it's due to acidity, and that's from the fatty food. So the milk will dilute the acid. The medication, the first one I have it here, is called Gaviscon. It's a little bit higher strength than milk, but we will start milk first. Milk, simple milk. And try to avoid the fatty foods and not eating too late at night.
Thank you.
Eating late at night is typical, yes, madam. But also after eating heavy meals, and fatty heavy meals. Correct.
Thank you, doctor.
Yes, sir.
Please, I want to ask a question. What could be the cause of constant chest pain?
Good. Is that in yourself?
Yes.
Okay. May I ask how old are you?
I am 29.
29. Where is the chest pain? Can you localize it on your chest? Where is it?
Yeah, like a kind of a pain you got from exercise when you stop like exercise for a while and
Yes.
then went to the exercise again. You got some pains.
Okay.
So,
Do you have any other symptoms? Do you have any nausea, vomiting,
yeah, so often have
sweating,
no. Just nose congestion.
and it's constant?
Yes, constant.
If you touch your chest, do you feel pain?
No.
So it's within. Okay. Do you have any other medical conditions?
No, that.
Okay. And so you said you work out in the gym.
I just use the gym as an example,
Yeah.
but I often feel pains on my chest, and I have went to many hospitals, but after giving the medication, there is no changes
Okay.
here in Cambodia.
Okay. So which medicine did you take? Do you know the name?
I don't think I could remember.
Did they do a heart trace?
Oh, well, I went to the X-ray about that, but after all said that, they said nothing is happening to me, but I still feel the constant pain.
And it doesn't go away. It's constant.
Yes, constant.
Is it sharp, dull? Can you describe the kind of pain?
The kind of pain is that like when I want to do like I'm like I kind of breathing faster, like when I want to do something like strong, I feel the pain.
Maybe when he wants to lift a heavy weight, he
Yeah.
feels a sharp pain.
Yeah. So I'm going to come to that. Just one more question. If you breathe in, do you get pain?
No, sir.
Any pain on coughing?
No.
Okay, this is atypical chest pain. Atypical. This most likely causes musculoskeletal, from the muscle or the bone. Okay? I don't know what's happening, but maybe related to the gym, but it's definitely not from the heart. Not from the heart at all. Okay? So it's atypical, happens quite common, affecting, because you have muscles and bones